Page 21. The End of Poverty, Economic Possibilities for Our Time, Jeffrey D. Sachs, 2005. Chapter 1. A Global Family Portrait. 1.1. Malawi. The Perfect Storm. It is still mid-morning in Malawi when we arrive at a small village, Nthandire, about an hour outside of Lilongwe, the capital. We have come over dirt roads, passing women and children walking barefoot with water jugs, fuel wood, and other bundles. The mid-morning temperature is sweltering. In this subsistence maize-growing region of an impoverished landlocked country in southern Africa, households eke out survival from an unforgiving terrain. This year has been a lot more difficult than usual because the rains have failed, probably the result of an El Nino cycle. Whatever the cause, the crops are withering in the fields that we pass. If the village were filled with able-bodied men who could have built small-scale water harvesting units on rooftops and in the fields to collect what little rain had fallen in the preceding months, the situation would not be as dire as it is this morning. But as we arrive in the village, we see no able-bodied young men at all. In fact, older women and dozens of children greet us, but there is not a young man or woman of working age in sight. Where, we ask, are the workers? Out in the fields? The aid worker who has led us to the village shakes his head sadly and says number. They are nearly all dead. The village has been devastated by AIDS, which has ravaged this part of Malawi for several years now. There are just 5 men between 20 and 40 years of age left in the village. They are not there this morning because they are all attending the funeral of a fellow villager who died of AIDS the day before. The presence of death in Nthandire has been overwhelming in recent years. The grandmothers whom we meet are guardians for their orphaned grandchildren. Each woman has her own story of how her sons and daughters have died, leaving her to bear the burden of raising and providing for 5 or 10, sometimes 15, orphaned grandchildren. These women have reached an age where, in more prosperous places, they would be the revered matriarchs enjoying a well-earned rest from a lifetime of toil. But there is no break now, no chance for even a moment's respite, because the grandmothers of this village, and countless others like it, know that if they let up for a moment, these young children will die. The margin of survival is extraordinarily narrow, sometimes it closes entirely. One woman we meet in front of her mud hut has 15 orphaned grandchildren, as shown in photograph 1. As she begins to explain her situation to us, she first points to the withered crops that have died in the fields next to her hut. Her small plot, perhaps a half-hectare, a little more than an acre, in all, would be too small to feed her family even if the rains had been plentiful. The problems of small farm size and drought are compounded by yet another problem. The soil nutrients have been depleted so significantly in this part of Malawi that crop yields reach only about 1 ton of maize per hectare with good rains, compared with 3 tons per hectare that would be typical of healthy soils. A half a ton of grain from a half-hectare field would not be sufficient for proper nutrition and would provide precious little, if any, market income. This year, because of the drought, she will get almost nothing. She reaches into her apron and pulls out a handful of semi-rotten, bug-infested millet, which will be the basis for the gruel she will prepare for the meal that evening. It will be the one meal the children have that day. I ask her about the health of the children. She points to a child of about 4 and says that the small girl contracted malaria the week before. The woman had carried her grandchild on her back for the 10 kilometers or so to the local hospital. When they got there was no quinine, the anti-malarial medicine, available that day. With the child in high fever, the grandmother and grandchild were sent home and told to return the next day. In a small miracle, When they returned the next day after another 10-kilometer trek, the quinine had come in, and the child responded to treatment and survived. It was a close call, though. When malaria is untreated over the course of a day or two, a child may slip into cerebral malaria, followed by coma and then death. More than 1 million African children, and perhaps as many as 3 million, succumb to malaria each year. This horrific catastrophe occurs despite the fact that the disease is partly preventable through the use of bed nets and other environmental controls that do not reach the impoverished villages of Malawi and most of the rest of the continent and completely treatable. There is simply no conceivable excuse for this disease to be taking millions of lives each year. Our guide to Nthandire is a Christian aid worker, a dedicated and compassionate Malawian working for a local non-governmental organization, NGO. He and his colleagues work against all odds to help villages such as this one. The NGO has almost no financing available and survives from meager contributions. Its big effort in the village, including this particular household, is to provide a piece of plastic tarpaulin to put under the thatch of each hut's roof. The tarp keeps the children from being completely exposed to the elements, so that when the rains do come, the roof will not leak on the 15 grandchildren sleeping below. This contribution of a few cents per household is all the aid organization can muster. As we proceed through the village, other grandmothers share similar stories. Each has lost sons and daughters. Those who remain fight for survival. There are only poor in this village. No clinic nearby. No safe water source. No crops in the fields. And notably, no aid. I stoop down to ask one of the young girls her name and age. She looks about 7 or 8, but is actually 12, stunted from years of undernutrition. When I ask her what her dreams are for her own life, she says that she wants to be a teacher, and that she is prepared to study and work hard to achieve that. I know that her chances of surviving to go on to secondary school and a teacher's college are slim under the circumstances in which she lives. Attending school now is a hit-and-miss affair. Children are in and out of school with illness. Their attendance depends on how urgently they are needed at home to fetch water and firewood, or to care for siblings or cousins, on whether they can afford to buy supplies, a uniform, and pay local fees, and on the safety of walking several kilometers to the school itself. We leave the village and fly later that day to the second city of the country, Nthandire, where we visit the main hospital in Malawi, Queen Elizabeth Central Hospital. There we experience our second shock of the day. This hospital is the place where the government of Malawi is keen to begin a treatment program for the roughly 900,000 Malawians infected with the HIV virus and currently dying of AIDS because of lack of treatment. The hospital has set up a walk-in clinic for people who can afford to pay the $1-a-day cost of the antiretroviral combination therapy, based on Malawi's arrangements with the Indian generic drug producer Cipla, which has pioneered the provision of low-cost antiretroviral drugs to poor countries. Since the government is too impoverished to be able to afford $1-a-day for all of those in need, the program has begun for those few Malawians who can afford to pay out of pocket. At the time of our visit, this treatment site is providing anti-AIDS drugs on a daily basis to about 400 people who can afford it, to 400 people in a country where 900,000 are infected. For the rest, there is essentially no access to anti-AIDS medicines. We duck into a conference room with the doctor who is overseeing the outpatient service and medical wards. He describes to us the small miracles of the patients on anti-AIDS drug treatment. The response has been dramatic. The success rate of the medicines is nearly 100%. The HIV strains do not exhibit drug resistance because the Malawian people have never had access to the drugs before. The doctor also reports that his patients' adherence to this twice-daily regimen has been very high. His patients surely want to stay alive. In short, the doctor is extremely pleased with the results. Just as his briefing is encouraging us, the doctor stands up and suggests that we visit the medical ward, which lies just across the hall. Medical ward is, in fact, a shocking euphemism, because in truth it is not a medical ward at all. It is the place where Malawians come to die of AIDS. There is no medicine in the medical ward. The room has a posted occupancy rate of 150 beds. There are 450 people in the ward. These 450 people are fit into a room with 150 beds by putting 3 people in or around each bed. In most cases, 2 people are lying head to toe to head, a stranger sharing a deathbed. Alongside or underneath the bed there is somebody on the ground, sometimes literally on the ground or sometimes on a piece of cardboard, dying beneath the bed. The room is filled with moans. This is a dying chamber where 3/4 or more of the people this day are in late-stage AIDS without medicines. Family members sit by the bed, swabbing dried lips and watching their loved ones die. The same doctor who is treating patients across the hall is the doctor in charge of this service. He knows what could be done. He knows that each of these patients could rise from the deathbed but for the want of $1 a day. He knows the problem is not one of infrastructure or logistics or adherence. He knows that the problem is simply that the world has seen fit to look away as hundreds of impoverished Malawians die this day as a result of their poverty. I have come to know Malawi relatively well after several visits. A few years earlier, I had been contacted by the Vice President of Malawi, Justin Mlaezi, a remarkably fine individual, a dignified, eloquent, and popular figure in what is against all odds a multi-party democracy. The odds are long because democracy is bound to be fragile in an impoverished country where incomes are around 50 cents per person per day, or around $180 per person per year, and where the stresses of mass disease, famine, and climate shock are pervasive. Amazingly, the Malawians have done it, while the international community has largely stood by through all of this suffering. Vice President Mlaezi himself has lost several family members to AIDS. The first time we talked about AIDS, he spoke to me through mournful eyes about his new responsibilities as head of the National AIDS Commission. He has led a team of experts to design a national AIDS strategy that could begin to meet this horrific challenge. That team has traveled throughout the world to Harvard, Johns Hopkins, Liverpool, the London School of Hygiene and Tropical Medicine, and the World Health Organization to discuss ideas for scaling up the fight against AIDS. Malawi actually put together one of the earliest and best conceived strategies for bringing treatment to its dying population, and gave an enormously thoughtful response to the challenges of managing a new system of drug delivery, patient counseling and education, community outreach, and the financial flows that would accompany the process of training doctors. On that basis, Malawi made proposals to the international community to help Malawians try to reach about a third of the total infected population, about 300,000 people, with anti-AIDS drug treatment within a 5-year scale-up period. Yet international processes are cruel. The donor governments including the United States and Europeans had told Malawi to scale back its proposal sharply because the first proposal was too ambitious and too costly. The next draft was cut back to a mere 100,000 on treatment at the end of 5 years. Even that was too much. In a tense 5-day period, the donors prevailed on Malawi to cut another 60% from the proposal, down to 40,000 on treatment. This atrophied plan was submitted to the Global Fund to fight AIDS, TB, and malaria. Incredibly, The donors that run that fund saw fit to cut back once again. After a long struggle, Malawi received funding to save just $25,000 at the end of 5 years, a death warrant from the international community for the people of this country. Carol Bellamy of UNICEF has rightly described Malawi's plight as the perfect storm, a storm that brings together climatic disaster, impoverishment, the AIDS pandemic, and the long-standing burdens of malaria, schistosomiasis, and other diseases. In the face of this horrific maelstrom, the world community has so far displayed a fair bit of hand-wringing and even some high-minded rhetoric, but precious little action. Page 26.